Begin with our part 4 video. So here let us see common knee condition. The first one we are going to discuss is unhappy triad. So unhappy triad is mainly because of the lateral force which is coming to the knee. For example, you can see here this is a person with the leg planted towards the ground, and you can see here the force is coming from the lateral side. This is the medial side of the leg, this is the lateral side. In the lateral side the force is called valgus force. If you remember, in the medial side the force is called varus force. Here the force is valgus force because it is coming from the lateral side, and the main thing here is there is rupture of anterior collateral ligament and also the medial collateral ligament because the force is coming from the lateral side. Here in this diagram you can clearly say here the force is coming from lateral side, here the anterior collateral ligament is damaged, and here the medial collateral ligament is damaged. Of course, even the medial meniscus will get damaged. You can see this is the medial meniscus, but the most commonly affected one will be the lateral meniscus because the force is mainly coming from the lateral side. So that is about unhappy triad. Now coming to pre-patellar bursitis. Actually, before the patella there is a bursa. This is called as pre-patellar bursa. When it gets inflamed, this is called as pre-patellar bursitis. Actually, knee have four bursa, that is a synovial lined sac. Among this bursa we are going to discuss now, but pre-patellar bursa, if it gets inflamed, then it is called pre-patellar bursitis. It is mainly causes are like infection and also gout. Now coming to popliteal cyst. So here you can see this is a popliteal cyst. If you remember, this is called popliteal fossa. So in that only there is a popliteal cyst. Actually this is a fluid filled cavity, that is synovial filled cavity, and this is in connection with the synovial space as you can see here. Okay, so when this get inflamed, that is called as Baker's cyst or popliteal cyst. If it ruptures, then it will mimic the DVT, that is deep vein thrombosis. Okay, so this popliteal cyst, if it becomes enlarged, that is called Baker's cyst, and this as it is in connection with synovial space, it may also lead to chronic joint disease like osteoarthritis because it will lead to inflammation of this place also, and also it may lead to rheumatoid arthritis, degenerative inflammatory joint injuries. Okay, so here you can see these are the three graphs on the CTMRI how they look. The first one A we can see is the anterior collateral ligament tear, which is clearly observed here, white one, and here what you can see is the posterior meniscus, and this is the anterior meniscus, and here you can clearly see this is the prepatellar bursitis. Okay, and here you can see the Baker's cyst. This arrow is representing the Baker's cyst. One more thing, this Baker's cyst is present in gastrocnemius and semimembranous bursa. That is important. In the muscles of gastrocnemius and semimembranous there is a bursa, and that gets affected in the Baker's cyst. Okay, and one more thing I want to see here is a patellar fracture. Patellar fracture is a trauma to the knee where there is swollen, painful knee, and it can't extend the knee against the gravity because there is no patella now because of trauma. So there's a loss of knee extension, and quadriceps tendon will also get tear. So there's injury to patellar tendon. So you can diagnose it by means of X-ray. Next, let us continue with common musculoskeletal conditions. So first one I'm going to discuss is costochondritis. Actually, you can see this is the costal cartilage and this is the bone here. Okay, in zoom you can see this is the bone, this is the cartilage. This is called as costochondral junction. So if it gets inflamed, that is called as costochondritis. Okay, so it is mainly due to some minor trauma or some injury, direct injury to the rib cage. Okay, so it actually presents with pleuritic chest pain and also focal tenderness to palpitation. So if you palpitate this, there will be tenderness. It will be more common in younger female patients, and sometimes it may mimic the myocardial infarction, pleuritis or pulmonary embolism also. So treatment will be analgesics, pain relief and stretching therapy. Next, I'm going to discuss about dechoreantinocytosis. Actually, this is a problem of abductor pollicis longus muscle and extensor pollicis brevis. Actually, these muscles, they are both useful for abducting the thumb and also for the extension of the thumb. Okay, so if these muscles get affected, then there will be pain in the thumb whenever you're using thumb. So these tendons are getting inflamed, and especially get pain at the radius styloid process. At that place, you can get the pain, and the test is what we do is Finkel's stain test, where there is a pain at radial styloid with active or passive stretch of thumb tendons, and there will be increase in risk, especially new mother, because they're always lifting the baby, and also golfers, racket sports players, thumb textures, all those have this problem mostly. Next, Next thing we're going to discuss is Dupuytren contracture. Actually, this is caused by the fibroblastic proliferation and thickening of the superficial palmar fascia, especially of fascia of base of ring and little finger. You can see this is the base of ring finger, base of little finger. Here, this is getting inflamed. This fibroblastic proliferation over here. So, this most frequently seen in males greater than 50 years, especially of North European descent. Next case is ganglion cyst. You can see this cyst-like condition. Actually, it is a fluid-filled cavity which you can see in the joint or tendon sheet. It's most common at the dorsal side of the wrist. You can see this is a palmar side. This is the dorsal side. So in the dorsal side, you can find this, and it is arising from herniation of dense connective tissue, and usually can resolve spontaneously. Next thing is iliotibial band inflammation. Actually, it is mainly due to overuse, like for example in runners. So the lateral knee is overuse, like lateral femoral epicondyle is with friction because of running. It friction with this iliotibial band and causes inflammation, and there will be pain, of course, because of inflammation. Now let us discuss about limb compartment syndrome. Actually, you can see here this is a tibia bone, this is a fibula bone, and this is the anterior compartment muscle, this is the lateral compartment, this is a deep posterior compartment muscle, superficial posterior compartment muscle. Actually, if you take a cut section here, if you see, it looks like this. So actually what is the problem here is the muscles are getting swelled. You can see all are tightly packed inside our leg. So if these muscles are getting swollen, then what happens is the vasculature, the veins, arteries, all those will get occluded, and that will lead to necrosis. Acute tubular necrosis is also seen in kidneys, and it is because of rhabdomyolysis and necrosis and anoxia. You can understand here the venous outflow is getting obstructed, and even there is arterial collapse. So because of this, there is severe rhabdomyolysis, like that is muscles are getting breakdown. There's also necrosis, and because of this, there's leading to acute tubular necrosis, and even there is long bone fractures, especially like tibia fracture. All these are the causes of this condition. Also uh, deep perfusion in injury, animal venoms, all these causes. They are with severe pain, tense, swollen compartments, passive stretch of muscles in the affected compartment. Increased serum, there will be increased serum creatine kinase because muscles are getting lysis, right? And there will be motor deficits, but there are late signs of irreversible muscle and nerve damage. Actually, in this syndrome, you can find out 5 P's, that is the pain, pallor, paresthesia, pulselessness, and paralysis. So that is about compartment syndrome. Next, we'll see the medial tibial stress syndrome. Actually, this is also called as shin splints. It's a common cause of shin pain. Shin is actually the tibial bone is called shin. So there will be shin pain and diffuse tenderness. It is seen especially in runners and military recruits. You can see this is the anterior shin splint, pain along shin bone and lower leg. This is a posterior shin place. It is caused mainly because of overuse of muscle tendons and ligaments. So it is causing this pain. It is mainly caused by bone resorption that outpaces bone formation in tibial cortex. So actually here there is more bone resorption. So it is like outpacing the bone formation in tibial cortex. Next, let us look at plantar fasciitis. Actually, this is an inflammation of plantar aponeurosis. You can say this is a plantar aponeurosis characterized by heel pain, worse with first steps in morning after the period of inactivity and tenderness. So it is mainly affected in obesity patients, prolonged standing patients, and jumping dancers, runners, and also in flat feet. So heel spurs are also often coexisting with this condition. So here you can see this is called as heel spur, like a outgrowth from a bone. You can see here this is a heel spur. Now let us discuss about temporomandibular joint disorders. Actually, they're group of disorders. They mainly involve, the temporomandibular joint will be here, and the muscles of mastication are affected. Actually, it is associated with temporomandibular joint trauma. So it will lead to poor head and neck posture. You can see neck and shoulder pain, and also abnormal trigeminal nerve pain processing. Also some psychological factors, and it will also lead to headache, migraine, ear pain or tinnitus, and also dental damage. You can see jaw pain, of course, because temporomandibular joint is affected, and it also presents with dull constant unilateral facial pain, which will worsen with jaw movement. So when you try to move your jaw, you get more pain. Of course, odalgia, headache, and TMJ dysfunction. There is a limited range of movement in your mouth area. Let us discuss about supracondylar fracture. Actually, it is the most common pediatric elbow fracture. It is seen due to fall on outstretched arm. And here the artery which is injured is a brachial artery, and median nerve also travels with the brachial artery, so median nerve is affected. So it will lead to injury to both the most common neurovascular structures like median nerve and also brachial artery. For example, if the lateral epicondyle is affected, then it may affect even the radial and ulnar nerves, so they will also get injured. And remember that ulnar nerve travel under the medial epicondyle. Next, we'll see the radial head subluxation. Here you can see the radial head subluxation. Actually, in childhood, these are the childhood disorders because in a child the annular ligament is not nicely formed. So when someone tries to pull their hand, their radius may get subluxated from the annular ligament. That's why called as nursemaid's elbow. Okay, so when you pull the arm, this immature annular ligament slip over the head of the radius, and the injured arm is held in slightly flexed and pronated position. So this is mainly caused by the axial traction on pronated forearm, and it is trapped in the radiohumeral joint or junction. Next, coming to Musculoskeletal disease. Actually, here the problem is in the tibial tuberosity. It is actually a secondary ossification center of the tibia. This is called traction apophysitis because actually it is an overuse injury by repetitive strain and chronic avulsion of secondary ossification center. It occurs especially in adolescents after the growth spurt and common in running and jumping athletes because they are overusing this. So this will progressively lead to anterior knee pain because of using it for a long time. Now coming to patellofemoral syndrome. So again, this is a patella, this is a femur. Actually, it is also an overuse injury. It is present in females, young females athletes. Here also they are having the anterior knee pain. It is exaggerated by prolonged sitting or weight bearing, especially on flex knee. So it's like when you flex and you get the pain because here there is a patella and only here also there is a femur bone. So at this side, this red area is where there is inflammation and also pain. So now let us see the developmental dysplasia of the hip joint. You can see here actually this is the acetabulum of the pelvis bone, that, and this is the femur. So they both articulate here, but here the problem is there's an abnormal acetabulum development in newborn. So the risk factor is breech presentation. It actually leads in hip instability and dislocation, and commonly tested with Ortolani-Barlow maneuvers. Let me show that. These maneuvers are called Ortolani and Barlow maneuvers. Here we can check out that they're trying to check out whether this femoral and acetabulum joint is nice or not in Ortolani, and this is the Barlow test. And you can see here this is confirmed mainly by ultrasound, not x-ray, because until 4 to 6 months there is because cartilage is still not ossified in this children, so we confirm it by ultrasound. Now let us see leg clave Perthes disease. It is idiopathic avascular necrosis of femoral head, and it is commonly present between 5 to 7 years with insidious onset of hip pain, and it may cause a child to limp. You can see here this is avascular necrosis. This dotted line represents normal where the femur head should be, but you can see this is the abnormal femoral head. This is because of this syndrome. It is more common in male children, that is 4:1 ratio, and initial x-ray is often normal. Next, let us discuss about SCFA. SCFA is slipped capital femoral epiphysis. Actually, you can see this red color represents slipping of the femur here. Actually, this is the normal where there is femoral head, growth plate, and the femur bone. But here the bone is getting slipped. So it classically presents in obese young adolescent with hip or knee pain and altered gait. Here there is increased axial force on femoral head, so the epiphysis displays relative to the femoral neck. So it is like a scoop of ice cream slipping from a cone. So it is diagnosed via X-ray. Now let us discuss about common pediatric fractures, that is the green stick fracture and Torus fracture. For example, you can see this is a normal bone, this is a complete fracture. Green stick fracture is that you can see the fracture only on the bone where there is lot of bending stress. So if the bone is bending towards this side, in this side there will be fracture, but on the compression side there will be no fracture. So for example, the compression is coming from this side, but the tension is towards this side, so this is a green stick fracture. Torus fracture is opposite to that, where there is compression at that side you can see a buckling of the bone, whereas on the tension side it would be normal. So this is the difference between torus and green stick fracture. Next, let us discuss about achondroplasia. In the name itself, you can see achondroplasia means there is no cartilage. So if there is no cartilage, endochondral ossification, where especially long bones require cartilage, they convert into woven bone and later into lamellar bone. So if there is no cartilage, then the long bones will be short, and that will lead to dwarfism. But their head will be normal. Their head will look oversized, but their long bones look shorter. This is because of achondroplasia. And here there is a mutation in FGFR3, that is a growth factor, fibroblast growth factor receptor. So because of this mutation also, it actually inhibits the chondrocyte proliferation. So if there is this mutation FGFR3, it will inhibit the chondrocyte proliferation. So because of that, there will be no chondrocyte, and that will lead to short-limbed dwarfism, most common short-limbed dwarfism, and it is an autosomal dominant condition. Next, let us discuss about osteoporosis. Actually, here the problem is there is more osteoclast activity. Whenever there is more osteoclast activity, there will be more bone resorption. But important thing is the lab findings are normal in the osteoporosis, like the calcium, phosphorus, alkaline phosphatase, all those levels are normal. But the bone is breaking down, that is, the bone mass is decreasing, so there is more rise of fracture risk. So whenever they fall, like any falls, then there is high risk of fracture because of osteoclast activation, and it is most common in trabecular bone. We know that bone have spongy bone, trabecular bone. For example, this is a bone, and here will be most of this will be the spongy bone or the trabecular bone, and the cortical bone. This will be the cortex of the bone. So the cortical bone and trabecular bone are mostly affected in the case of osteoporosis. Their mass is decreased, and this one you can see especially in spine region, and also in the head of femur, and also in the wrist. And this condition is most commonly in elderly white female. So, and one more thing is it is also related to estrogen, and in older ages, because there is more osteoclastic activity increase in older ages, and osteoblastic activities decrease. Whenever estrogen is decreased, there will be decreased OPG, and where is decreased OPG, the rank ligand binds more often to rank receptor on osteoclast. So this will lead to increased osteoclast activity. And also the steroids, alcohol, anticonvulsants will increase this. Anticonvulsants will increase P450. So as they increase P450, it will increase the parathyroid. Parathyroid function is to increase the calcium level in the blood serum. So what happens is whenever there is PTS, more osteoclast activity. Even anticoagulants like unfractionated heparin will lead to osteoporosis. Thyroid replacement therapy, because hyperthyroidism, it will lead to osteoporosis. So in thyroid replacement therapy, as you are giving more thyroid, artificial thyroid, especially to hypothyroidism people, that will also lead to increased osteoclastic activity. And also in hyperparathyroidism people, in multiple myeloma, in alcohol smoking, and malabsorption syndromes, and roxia. In all these conditions we can see this. So we use a DEXA scan, that is a diagnostic for this, that is a dual energy X-ray absorptiometry. And this DEXA scan especially we find out in the lumbar spine, total hip and femoral neck, because these are the common sites. So if the T-score, we actually get a T-score out of DEXA scan. If this T-score is less than -2.5, or by a fragility fracture, like a fall from standing height, minimal trauma at hip or vertebra, then we can easily say it is a osteoporosis. Especially there will be kyphosis in elderly. In elderly, if you see, they are like bending. Why they are bending? Because of the vertebral compression factor. In this diagram you can see this is a normal intervertebral disc, but in the mild compression fracture, vertebral compression fracture, is a central expansion of intervertebral disc, and there is a restricted intervertebral foramen. So because of this, there is acute back pain, loss of height, especially due to kyphosis in elderly. So they present with fractures of femoral neck, distal radius. Distal radius in the hand will lead to Colles fracture. So it's advisable for every female who is greater than 65 years old, one time screening of DEXA scan for their osteoporosis. Prophylaxis is regular weight bearing exercise, adequate calcium, vitamin D intake through adulthood. Treatment can be bisphosphonate, teriparatide, that is a low amount of parathyroid. SCRMs can be used, rarely calcitonin, denosumab. Actually, denosumab is an, whenever you see any drug AB, that means it's a monoclonal antibody. Actually, it's an antibody against the rank ligand. Rank ligand, it is present in osteoblast. So, if you produce antibody against rank ligand, then the rank ligand can't bind with the rank receptor on osteoclast. So, this will inhibit the osteoclastic activity. So, one more thing, the T scores. The T scores in osteopenia is between 1 to minus 2.5, but not less than 2.5. So it is a somewhat better condition when compared with osteoporosis. In osteoporosis, the T value is less than minus 2.5. In osteopenia, it is between 1 to minus 2.5. Next condition is osteopetrosis. Here the problem is that osteoclast is not present. There is overproduction of osteoblasts. So whenever there is more production of osteoblasts, there will be more bone. Especially it will lay down most of the cortical bone. So because of that, you can see this over white regions on X-ray. But this is because of more osteoblasts. But like this also the bone will become very big because of osteoblasts, and this is called as osteopetrosis. Here the problem is with a gene called carbonic, like mutation is in the carbonic anhydrase 2. So this is divided into two types, like autosomal recessive infantile form and autosomal dominant. Autosomal recessive infantile form is where there is carbonic anhydrase type 2 gene mutation. In autosomal dominant form, there's Albert-Schonberg disease, and it is seen in adolescent. It is actually a milder disease, and it is asymptomatic. It is identified by X-ray. So coming to here, this osteopetrosis. So as there is more bone growth, what happens is the blood cells can't form, that will lead to pancytopenia. All the blood cells are decreased, and that will lead to extramedullary hematopoiesis, because here whole of the bone is filled with bone and there's no place for hematopoiesis. So spleen or liver now may start producing blood cells, and they will be nucleated because they are extramedullary, and can result in a cranial nerve impingement. Because why cranial nerve impingement? Because even the head bones all will increase in size, and they're deposited with lot of calcium. So because of the cranial nerve may impinge, and the different pulses which will narrow the foramina. So this may lead to hydrocephalus, deafness, facial paralysis, vision loss, and X-rays will show diffuse symmetric sclerosis, that is a bone in bone, which is also called stone bone. And the bone marrow transplant is curative, because that osteoclasts are also derived from monocytes. So if we give the bone marrow, not only this osteoclasts are produced, also there is pancytopenia, right? So all those cells will recover back because of bone marrow transplant. Next condition is osteomalacia or rickets. It is actually due to deficiency of vitamin D. So when there is no vitamin D, there's no calcium formation, and because of that, there will be a defective mineralization of osteoid. So the bone can't form properly, that is leading to osteomalacia. And in rickets, the problem is there is vitamin D deficiency, and that is leading to less cartilaginous growth. You know that long bones require cartilage, and that will convert to woven and next lamellar bone. So if there is no cartilage, then there will be no normal growth in rickets. So in the both conditions, either in osteomalacia or rickets, there is a problem of vitamin D. So that will lead to pseudo fractures, looser zones, inadequately mineralized, erosion of bone by arterial pulsations. The bone will become very weak, that even due to arterial pulses, the bone will get narrowed. And X-rays will show osteopenia and pseudofractures, especially in osteomalacia. There will be epiphyseal widening and metaphyseal cupping or fraying in rickets. Children with rickets have bow legs. You can see this diagram. There's a bow legs, also called genuvarum, and there will be the bead-like costochondral joints. That this is called as rachitic rosary, and also the soft skull. Skull will become soft. That is called craniotapes. So here the problem is decreased vitamin D, decreased serum calcium, increased parathyroid, because there is decreased calcium, and that will lead to, as parathyroid is increased, that will lead to decreased phosphate. Here there is increased alkaline phosphatase, because the body is trying to produce more bone now, because there's low bone already because of vitamin D deficiency. So there will be increased alkaline phosphatase, and there is hyperactivity of osteoblasts. The treatment is vitamin D and calcium supplementation. The best test to indicate for vitamin D status is 25 hydroxy vitamin D, which is actually produced from the liver. And you know that 125 hydroxy vitamin D is present in the kidney. So next let us discuss about osteitis deformans. This is also called as Paget's disease of bone, and it is the disorder of bone remodeling which is caused by increased osteoclastic activity followed by increased osteoblastic activity that forms a poor quality bone. So here the problem is, first, the osteoclast is increased. As the osteoclast is increased, most of the bone is getting destroyed. So now our body tries to increase the osteoblast now. It is trying to increase more bone now. Because of this, there's a poor quality of bone. So serum, calcium, phosphorus, and parathyroid all are normal, same like osteoporosis. In osteoporosis also all lab values are normal. But here the alkaline phosphatase is increasing now at the end because osteoclast has degraded all the bones. So now osteoblast tries to increase all the bones. So it requires the alkaline environment. So alkaline phosphatase is increased, and there's a mosaic pattern of woven and lamellar bone. Osteocytes within the lacuna in chaotic juxtapositions, long bone chalk stick fractures, increased blood flow from increased arteriovenous shunt may cause high output heart failure. So this osteitis deformans, there's a risk of high output heart failure, and there's also increased risk of osteosarcoma. And here in this diagram especially you can see the head size is increasing, that is the head size is increasing, skull is getting thickening, and you can also see a radiculopathy at the right spine. And here you can see these are the three stages of this Paget's disease. First one is early destruction, that is lytic because of osteoclast. This is intermediate, that is mixed, that is because of osteoclast and osteoblast. In the late stage there will be sclerotic or blastic, that is osteoblasts are increased, so the alkaline phosphatase is also increased. So later it may enter the quiescent phase. The treatment is bisphosphonates, calcitonin, that's it. So next let us discuss about avascular necrosis. Actually what is avascular necrosis of bone? That is the decreased blood supply to the bone, so it will undergo the necrosis. So here the infarction is mainly caused by the medial femoral circumflex artery. So this artery is destroyed. So this is leading to avascular necrosis. Especially it is most common in the femoral head, that is the watershed zone. And the causes are like glucocorticoids, alcohol overuse, sickle cell disease, trauma, SLE, and also Cassins decompression disease, leg clavipathies disease. About this disease we discuss in pediatric conditions, and also Gaucher disease, slipped capital femoral epiphysis. All these conditions are leading to avascular necrosis. And the mnemonic is cash, bend, legs. Cash, C for glucocorticoids, A for alcohol, S for sickle cell disease, T for trauma, and S for SLE. So cash, bend, legs. Now let us continue lab values and bone disorders. So first thing where the lab values will be normal is in two conditions. One is osteoporosis and Paget's disease of bone. But in Paget's disease of bone, the alkaline phosphatase will be high because at last in Paget's disease, osteoblast is high. So to form more bone, alkaline environment is required. So LP is high. Next, osteopetrosis. You know here the osteoblast is more. So the calcium will be low here because osteoblast is building the bone, and phosphate will be normal, ALP will be normal, and parathyroid will be normal. Next, coming to osteitis fibrosa cystica. Actually this is seen in hyperparathyroidism. So here first the parathyroid is high. As the parathyroid is high, the calcium will be high, the phosphate will be low, and the alkaline phosphatase will be high. Next, secondary parathyroidism. Here because there is low calcium, there is high parathyroid. So because of that there will be high phosphate, and also as there is low calcium and high phosphate, parathyroid is released, so parathyroid will be high and ALP will be high. Remember that ALP is high in Paget's disease of bone, osteitis fibrosa cystica, secondary hyperparathyroidism, and also in osteomalacia and rickets. In osteomalacia and rickets there is low vitamin D, low calcium, so low calcium, low phosphate, high LP, and high parathyroid because there is low calcium, so high parathyroid. Next, hypervitaminosis D. Here the vitamin D is more high, so calcium will be high, phosphate will be high, but ALP will be normal and the parathyroid will be low because there is already high calcium, so parathyroid will be low. So these are the lab values we need to remember. So in the summary of this all these bone diseases, we can just remember this flowchart. Whenever there is bone pain or fracture, if there is normal calcium and normal parathyroid, that is in osteoporosis, also in osteopetrosis and Paget's disease, and also in bone tumors. In all these conditions, there will be normal calcium and normal parathyroid. Next, decreased levels of calcium, so parathyroid is increased. This is seen in calcium, vitamin D deficiencies, and also in malabsorption. Increased parathyroid and increased calcium. This is seen in osteitis fibrosa cystica and also where there is PTH adenoma, so there is increased PTH. So normal calcium, normal parathyroid in osteoporosis, osteopetrosis, Paget's disease, and bone tumors.